I would like to introduce Dr. Christina Pardo. Dr. Pardo, as a member of the Downstate Department of Obstetrics and Gynecology, serves as Clinical Assistant Professor, Director of Health Equity, and Vice Chair of Quality Improvement and Innovation for that department. She graduated from Howard University in 2004 with a BS in biology, attended Rutgers Robert Wood Johnson Medical School in New Jersey, and completed a master's in public health at Boston University with a concentration in international health. Because of her desire to work with underserved and immigrant communities, she went on to complete residency in obstetrics and gynecology at SUNY Downstate Medical Center in Brooklyn, New York. Throughout her education and training, she traveled abroad and worked with several global health organizations, including the Fogarty International Minority International Research Training Program in Ethiopia, um, Project MetaShare, and Partners in Health. Additionally, she was involved with GHESKIO. I'm not quite sure, but I believe that that's affiliated with her time in Ethiopia. Welcome, Dr. Pardo, and unmute.
Yes. Thank you. Thank you very much for the introduction. Want to make sure I thank President Riley, Dr. Salafu, Dr. Patel, the Brooklyn Health Disparities for inviting me to participate in this symposium. And, you know, I am happy to follow that great talk by Jasmine, and hopefully we'll continue to set the stage for what we will have this evening. And want to make sure I acknowledge Dr. Lavius. I must be doing something right because there's a second panel I've had participated with you in the past couple of months. So I look forward to your talk. I'm going to share my screen. As stated, I am within the Department of Obstetrics and Gynecology. And have a role of Vice Chair of Quality and Innovation, as well as Director of Health Equity. And I'm going to focus a talk on, I think, setting the stage for why this is important and how do we integrate equity into practice and research. And I include practice because I think now we see more than ever, and linking the two is essential if we want to achieve equity for the communities that we serve. And I do not have any disclosure. So I'm going to build this case through using obstetrics and gynecology and what we have done and what we are trying to do within the department. So to start quickly from the beginning, we know why women's health disparities has, in the past couple of years, come into the forefront, and that is because of the graphic on the left, which is the increase in maternal mortality rate within the United States compared to other quote-unquote developed nations. And on top of that, with the high health expenditure in which we have. So as we've taken a deeper dive as to now, why is that? After that Lancet report was released, I believe in 2016, we see that the root cause of that is the black-white health disparities that exist within the United States as it relates to maternal deaths, in which Black women are significantly have higher risk of dying related to pregnancy related complication compared to their white counterparts. And we see that even compared to other countries such as Brazil and Malaysia, unfortunately, the statistics are comparable for Black women. And as we've gone, deeper dive following that report, we see that not just for Black women, anytime we see a marginalized, minoritized community, you're going to see that increased risk. So here we see even for indigenous communities that there is an increased risk compared to white counterparts. And unfortunately, there was a time where there was a belief that this may adjust based on social or economic conditions. But what we have found, or what has been shown, is that education is in fact not the great equalizer, where Black women, even with higher level of education, still have a higher risk of a maternal related death. And as with many things within medicine, this does not remain within obstetrics. So the women's health disparities does extend beyond that, where Black women are more likely to experience unintended pregnancies, less likely to have lower percentages of IVF cycles, have higher death rates as it relates to endometrial cancer, as an example. And just a nod to my global health platform, maternal mortality is often deemed as like a measure of inequity. So I appreciate this map because it shows that wherever you see higher levels of maternal mortality is usually countries where there are higher degrees of inequity based on social status, where higher degrees of poverty, where there may be a power imbalance. And wherever you see inequity in community, inequity in society, you're going to have higher rates of maternal mortality. And that also goes for infant mortality. Wherever you see higher rates of maternal or infant mortality, you are more likely going to have more inequity in those societies. So as we have now followed this since that Lancet report was released, and have taken a deeper dive about why are these disparities in maternal outcomes occurring, why are they worsening, there has been a turn to another metric called severe maternal morbidity, because maternal mortality is still considered a rare incidence. It makes it harder to study. And so now there's turned into a focus into severe maternal morbidity, which is a life-threatening illness or a high-risk outcome within a pregnancy that can be considered as a near miss. And because those rates overall are higher, there's been a turn to that to understand more what is contributing to maternal health disparities. And so as we see over time, and this graphic is from the CDC, that severe maternal morbidity, just like mortality, has been increasing over time. And if we focus here on New York City, there has been a 28% increase from the last year that we have available, I believe is 2013. But between 2008 and 2012, and much like maternal mortality, Black women are more likely to suffer from a severe maternal morbidity. And what else has been found? That those living in high poverty neighborhoods have the higher risk of suffering a severe maternal morbidity. And other community level indicators are associated, like inadequate housing, residential segregation, and lower educational attainment. And just to show that, as most of us know, this is not centered just within maternal mortality, but same thing within infant mortality, where we see these disparities in the United States, unfortunately, on the higher side of the curve as it compared to other nations. And health disparities, again, setting the stage, differences in quality of care, differences in access to care, and differences in underlying exposures and opportunities. And so we're going to delve deeper into that, and how do we hopefully incorporate that into our research and practice. Most of what is causing the health disparities is outside of the institutions, the socioeconomic factors before the patient arrives into the door. initially, when there has been this increased focus nationally on health disparities, the social determinants of health became somewhat almost like a buzzword. Increased focus on social determinants of health among those that perhaps that wasn't a focus within research or traditional medicine practice and education. And we know the social determinants of health is all that surrounds us, including our healthcare systems, including our community and social context, and how all of that contributes to health outcomes. And fortunately, because of organizations like the Brooklyn Health Disparities Center and Dr. Lavias, we do have a literature that does support how these socioeconomic factors does contribute to our health outcome. But there was a feeling that there was a lot of focus on social determinants of a lot of without really kind of delving deeper into where is that coming from. What are the root determinants of that? And of course, Google is our keeper of everything. And so you see that there was this kind of started increase in search about the social determinant of health between the trends. And even among PubMed articles, we see that after between 2010 and 2020, you have a spike in articles published specifically on social determinants of health, again, because of this renewed focus, at least nationally, outside of centers that were specifically focused on that. But as we talk about social determinants of health, one thing I like to say is it the disease or the symptoms? So the social determinants of health, the differences in the way what the socioeconomic factors are really a symptom of a root cause disease that we are finally starting to address more strongly, and seeing how we can integrate that into both our research and practice, and to use the term by Dr. Kamara Jones, a structural determinants of equity, understanding that this is, part of a spectrum. So we have, of course, the individual contributors to health disparities, then the community level social determinants of health, and going beyond that, what is contributing to these differences in our socioeconomic environments, and that being the determinants of equity, root cause of which includes structural racism, inequity in society, how are our economic systems built, our class structures, what do the isms play a role, how do the isms, racism, sexism, etc., play a role in health disparities. And structural, when we structural racism or inequity, the most important thing is that there is an imbalance. There is an unfair imbalance in access to social, economic, health, political, financial systems that is showing what we see in front of us. So that what we see in front of us may be the health disparities that we see in our patients, maybe housing segregation, access to healthy food options, racial wealth gap. These are what we see, the going downstream effects of the root causes of racism and inequity. The most common of which that has been discussed is housing segregation. And I always like to show, especially for those of our students and those who are training who are in Brooklyn, we hear so much of it in Brooklyn, but unfortunately this is not just a Brooklyn phenomenon, and is present in many cities throughout the country. And you will see the similar maps that we see for Brooklyn, where certain communities have increased risk of certain health outcomes like asthma, mortality, many things that you can list, and you will see a similar graphic for those countries. And the last part I just want to focus on before we move forward is, again, as we study this more, understanding intersection of different factors that contribute to health disparities. So as we have discussed, race and ethnicity as a contributor to health disparities. For actually, this is an article that came out earlier this year, in where the communities with the highest mortality were those were Black living in rural communities. Again, rural communities will have barriers to care. They might be different than those that we see here in urban communities, but they still will have the socioeconomic factors that are contributing to their health outcomes. And the root cause, as we said many times, for much of this is racism. And as we've delved deeper into this, we have accepted or come to understanding that racism displays itself in many levels. So as we go about our inquiry and as we go about our practice, an understanding of those levels really are essential. And that includes starting with the interpersonal, the internalized racism, the interpersonal discrimination and bias. So there's been a lot of focus on implicit bias and racism that contributes to disproportionate health outcomes. The institutional, what policies at institutional levels may contribute to disparities. And these are not just in health. Obviously, this is almost in every sector of society that these play a role. We have the community level, and then of course our root cause systemic and structural level. So as we move forward in inquiry and practice, there are avenues for study, investigation, education in each aspect of these, if we want to properly address health disparities. And I think the hardest to conceptualize, to study, to educate, or for acceptance, is that interpersonal aspect. But this is what I see, the interpersonal racism is what I see has become much more prominently discussed compared to previously. And to give an example of what was done in New York State, actually, in response to the maternal health disparities, when the New York State commissioner did listening sessions throughout New York State, and that helped them to formulate their programmatic plans and policy initiatives to address maternal mortality. And the barriers that were learned from this, qualitative work that they did throughout state was that access to care was noted throughout, poor communication with healthcare provided, feeling as though lack of information, racism and impact on the quality of care, disrespect from healthcare providers, and lack of social support. And had this extra step to listen to, which is, I think, has been to understand the patient experience, which has been a little bit more novel as far as research and quality improvement. Some of the initiatives that come about as a result of this may not have been implemented, and it's difficult to hear some of what was reported. But this is, in growing the evidence and support in the way racism plays a role in health disparities. It's not something that is easy quantifiable, especially as it relates to research methods, but it's something that is obviously evident and playing a role in health disparities. And some recent articles actually that were just published similar to this, and this was a title of one of them. Just because you have ears doesn't mean you can hear. So this was actually a qualitative work that was done here in New York City, in which they found perceived racial ethnic discrimination during childbirth influences patient-provider communication and is potentially a modifiable aspect of the patient experience. And if we move now, so that was focus groups that was done within one institution. And again, adding to the support of how racism plays a role, when severe maternal morbidity was the focus of inquiry, one of the contributors to that was quality of care at institutions that were provided. And of course, for institutions, in my view, are part of the social determinants of health. So they are a reflection of the resources, the allocation of resources that are available to a community. And so what this group that looked a little bit further into severe maternal morbidity, they wanted to look within one institution. Do those disparities exist, rather than just by neighborhood level? And they found that even within institutions, the Black-white disparity in severe maternal morbidity persisted. And it still, even after controlling for social, demographic, and clinical characteristics, it still persisted, and it wasn't reliant on the insurance status. So whether they had public funded insurance or private funded insurance. So this is something that is in all the institutions, whether you work in an underserved community, whether you work in a hospital that serves more affluent communities. And this is part of the supporting evidence of how interpersonal and institutional racism can contribute to health disparities. And there have been articles published within pain management differences, having medical students in 2006 study in which students actually had inaccurate beliefs on how inaccurate beliefs about Black patients. So, for example, whether they had thicker skin compared to white counterparts, as an example. So I think, we know that this is something that is important, and now we move to how can we study it, and how can we properly measure and address it in health disparities. And of course, we have the most recent thing that has kind of put this into play, which is what has happened with COVID-19 and what has happened with the acts of racial injustice, where we see more and more institutions now calling finally racism a public health crisis. But how do we take all of that? And there has been a traditional way we have been taught medicine. There's been a traditional way of how we've been taught to investigate. And so how do we take all of that and integrate it into our practice and research inquiry? And thankfully, there have been many thought leaders and many in research and academic leaders who have started to put out frameworks. And I think most importantly for us to start with incorporating a framework of justice, humility, and innovation in all aspects of the work that we plan to do, whether that be through research, education, or practice. And we'll go a little bit further into that. And the most important tenets as we move forward into this work is community first. Always remember community. When I engage with community organizations, it's always, I always have they always remind me, they always knew before we knew. They understand what is going on in the community before we understand. They understand the discrimination that may be happening. They fully understand the differences in health disparities, and they really can help us to decide what is the best way to move forward. Research justice, and as Jasmine so eloquently stated, understanding the injustice that have happened in the past, how that has affected the trust of patients in our community, how there may be false assumptions, there false evidence that is present based on faulty assumptions and bias in the past. And how do we integrate that into our practice? And I believe strongly that is through quality improvement. So linking research and practice through quality improvement, understanding the metrics of what is happening within our institution and applying strategies to improve them. And all of this requires really a paradigm shift in the way we have been traditionally taught, and to how we have been traditionally practiced over the years. And it's important that because this is rooted in a long history of structural racism, it's important for us to understand the past, to understand the best way to move forward. And the first kind of unfortunate is that there is not anything new about what has come out in the past couple of weeks, past couple of years. There have been many reports over the past century documenting the disparities and providing pathways to properly address it. What has changed now is that there is a renewed focus that is not just within medicine, but across the country, and the community engage in pushing this forward, and having leaders such as many on this panel that are helping to push this forward. So we have a unique time period where we can take what has been known historically and start to hopefully advance real change. And I'm not going to go much into this because Jasmine actually mentioned this previously, but unfortunately we have a prime example of how history has affected current in gynecology, in which the birth of American gynecology was rooted within the use of improper experimentation on those that are enslaved. So how do we move forward? So now focusing on the justice. So really first challenging everything, having a systemic analysis of hierarchy of knowledge. If, for instance, now there's a push in looking into GFR as an example, where was the evidence for GFR, and that is now being challenged. Even within obstetrics, there are algorithms that decide if Black women are less likely to have a successful vaginal birth after C-section. How is that algorithm established? How do we challenge that? How do we use study and inquiry to challenge that and prove those to be false? And then bringing that into quality improvement, looking at the research and practice so that we can actually change what is happening on the ground for patients. And as we are doing that, doing this simultaneously with the community. So the community always first, they know best. And they know the best ways to gain the trust, the best ways to have to navigate the community, even when it relates to research, and the best ways to develop successful and effective implementation plans. Humility, being uncomfortable with the uncomfortable. Whenever we talk about racism, this is an uncomfortable topic. When we talk about bias, this is an uncomfortable topic, but we have to be comfortable in understanding there's a lot that we do not know. There's a lot that we do not understand, especially in this realm. Being able to listen to our colleagues, perhaps in other disciplines, listen to the community to innovate and decide on the best methods of the way to move forward, centering the community voice in knowledge. Even if we feel that a certain pathway or method is the best way, understanding how is this centering the community? How can we have the community voice in the work that we are doing? And to move on to quality, which has become one of my central focuses, because I believe this is the way we translate the research and the education into equity for the patients. And this quote by Dr. Joy Currier-Perry, who's been really a leader within maternal health disparities, where there is no quality without equity. So even when we look at quality improvement, which looks at things usually as a whole, within that as a whole quality, we may be missing how the most marginalized communities, what disparities may be within our system. So we have to take an active look to see how certain communities may differ in outcomes. Disaggregate our health outcome data by race, ethnicity, and language, and not just on the outcome, focus on the how. All right, we talked about the racism and discrimination. How does racism play a part in the health outcomes? How does discrimination play a part in health outcomes? And some of the focus on that has been in the unmet standard of care. Is there a difference? Are certain communities more likely to have an unmet standard of care than other communities? And this may not, again, the focus not just on race, but on ethnicity and language. So depending on what your community looks like, what is the diversity of your community? Here, we happen to serve a diverse community based on ethnicity, immigration status, and language. Are there differences within that? If depending on where you look, you should seek out who may be the most marginalized community and delve deeper into that. And incorporating patient-reported experiences into quality improvement. What are the patients saying about their experience? And to show some work that has been done within obstetrics on this focus on quality. Again, this was published this year, and California has done a lot of work on this, where this group evaluated the impact of hemorrhage, quality improvement collaborative on racial disparities and severe maternal morbidity from hemorrhage. So they did this with intent. So they know that there were racial disparities. They studied the racial disparities. They developed programming that included equity and acknowledgement of bias and racism, and studied the impact of their intervention. And what they found is that they reduced rates of severe maternal morbidity due to hemorrhage in all races, and not just all races, and reduced the performance gap between Black and white women. And another focus on the quality patient-reported experience. And so this is something really exciting that's being developed also from California, where they have the sacred birth study, where because of the belief, or now the awareness, that traditional quality improvement initiatives have failed to include an equity-based lens, they are developing a patient-reported experience measure of obstetric, what they have titled obstetric racism. So again, using scientific rigor inquiry to develop novel and innovative ways to study and hopefully improve the experience and outcomes for patients. And we also have to make sure we look at ourselves in academic structures. The bias and racism within academic structures and disparities have been published on the different disparity of AOA membership. These are just examples, disparities in academic and again, another testament to why this translational program is so important, having more diversity at the table, more diversity at who is doing the research. And it's interesting, there was a study that came out, I think it was this year, that one of the reasons why there is a disparity in NIH funding is because of the type of research that minorities are more likely to be interested in doing, which will be around population-related work, things that focus on socioeconomic factors. And so now we're seeing how that potential bias could, have led to, the unfortunate outcomes that we still have today. So, we're thankful for this program and NIH and others for starting to understand the importance of this. And to show, again, the hope and is here, and we're moving things forward. Obstetrics and gynecology, just in the past couple of weeks, have put out a statement on the collective action addressing racism, and have a several point plan, which includes education, research, quality improvement. So we are starting to move the needle nationally on integrating racism, discrimination into our inquiry and practice, and not just on the outcome, but in how they are affecting the outcome. And I'll end with just saying what we are doing, how we are trying to focus on that within our department. And this is, again, based on what has we've been fortunate to have already been published on this with the platform of justice, humility, and innovation, combining community engagement, education, research, and quality, and avoiding any silos of those. So as we said, integrating research into practice through quality, bringing the community into our education and research so that we can move things forward. If I can say the one thing that I have felt has most impacted for the past year and a half that I have been here in impacting our education, impact in the research interest of the department and our quality, has been the Community Advisory Board. Definitely having the community voice speak directly to the department and directly to what they view is happening led to an almost immediate change and interest in focusing in these aspects within all three of those. And again, working interdisciplinary throughout the university, having a multidisciplinary approach is essential as we move this forward. Working with doulas, working with nurses, working with midwives. I'm just using obstetrics as an example, and I'm sure in other disciplines they have similar examples of how to do things in a multidisciplinary fashion. To summarize again, this is a graphic from California showing the multiple levels of intervention that are required for equity. And for each of these interventions, both inquiry, research, and practice have an essential role, and I think are essential that they are linked. Intersector and multidisciplinary in both inquiry and practice are essential. Looking at how place-based and multi-sector initiatives can play a role in this. Diversity and inclusion, so diversity in experience, diversity in thought, diversity in background are important to having innovative avenues in ways that we can address this. Having equity and justice as part of our platform in all of these things. So challenging what has been assumed or what has been proven to be just challenging assumptions we have made about our community, challenging anything that may serve as a barrier for advancing equity for our community, and obviously training the next generation. And I know Dr. Elke is coming up, and I'm sure will speak to us a lot about advocacy and policy reform. And if all else goes well, just listen and trust and respond to Black women always. And this is just obviously for maternal mortality, but to listen to those who are marginalized, those who are minoritized in our inquiry and in our practice as we aim to continuously evolve and improve outcomes for our community. Thank you.
Thank you, Dr. Pardo, for a very intriguing presentation.